All right. Well, good morning and good afternoon, depending on what coast you're on. It looks like we have people just driving in. These numbers are spiking quickly. So I'm so excited to see all of you with us today. My name is Carrie Scott. I work at Spruce Health. Hopefully you've joined me on one of these before, but if not, and you're new, welcome. We have a really exciting topic today. And that topic is U.S. federal and state telehealth law and policy. And we have an incredible speaker joining us, Thomas, who goes by TJ Ferrante. He is an attorney with Foley and Lardner, and he's going to be guiding the discussion today. Now, before we get started, just a couple of quick housekeeping items. Please use that Q&A button, that feature down at the bottom of your screen, to drop in any questions that you have as we go. TJ will see that come in, and if it's relevant to the slide we're on and the material he's covering, he'll answer it in real time. Otherwise, we're going to save those questions, and we'll have about 15 minutes at the end to go through them all. So please do ask your questions while we have TJ with us live today. We've disabled the chat feature, so questions is the place to go. Also want to just let you know that this session is being recorded. So if for some reason you need to drop off early or you miss something, I will be sending that link out to the recording later today, and you'll be able to revisit any part of the presentation. So with that, let's get started. We have such great content to cover today. On this slide, you'll see our agenda. So we're going to get a quick intro on who TJ is, quickly touch off on what Spruce is for those of you who are new to us today. And then we're going to get into the meat of it. TJ is going to cover off on the current regulatory landscape as it relates to digital health, the key considerations when using telemedicine to prescribe controlled substances under DEA rules, new opportunities for remote patient monitoring services, and ultimately what to expect for the remainder of this year. With that, let's get into who TJ is. So TJ, as I mentioned, is an attorney, a healthcare lawyer with a practice focus on telemedicine, telehealth, digital therapeutics, and virtual care. Also a wide range of transactional and related regulatory issues for health industry clients. And that includes hospitals, health systems, assisted living facilities, providers, and startups, all to build telemedicine arrangements across the US and internationally. So TJ is our resident expert today, and he does speak to this subject matter fairly frequently. So we're going to be able to learn quite a bit from him, and excited about that. Now, what's Spruce, for those of you who don't know us? Spruce is a healthcare communication platform, and it's designed for all of you on this call today, facilitating easy HIPAA compliance. It does consolidate communication channels across business phone, fax, text, and telemedicine into one unified solution. People like to say that it's like having their office in their pocket, and we believe that that is in fact true. You can take Spruce with you anywhere that you are across devices, and it makes your work far easier optimizing workflows. So if you have any questions on Spruce later on, feel free to tap me for that. Otherwise, we are going to get started and let TJ take us away on the topic at hand. Thank you so much for joining us, TJ.
Great. All right. I think everyone can hear me. Good afternoon. If you're on the East Coast like I am, and good morning, or if you're somewhere else on the West side. My name is TJ Ferrante. Again, I'm a healthcare attorney and partner with Foley and Lardner, and my practice focuses exclusively in the healthcare space. That's what I live and breathe every day, and specifically, the majority of my practice is working with healthcare industry clients to build out and operate digital health arrangements and models that are scalable. And at Foley, I think it's fair to say we probably do more digital health and telehealth work than any other law firm in the country. And I work with clients who range from large, sophisticated academic medical centers, hospitals, and health systems, but also have a growing portion of a demographic that are smaller or more earlier stage, but still very innovative type of companies, to help them understand how they can build exciting models and use healthcare technology to scale nationally. So happy to leverage that experience that I have and pour it into the presentation today, and spend some time with you all here with me. And I hope you find it helpful and valuable. But of course, I wouldn't be a lawyer, and I wouldn't do a lawyer things without any disclaimer, right? So just letting everybody know that we are not establishing an attorney-client relationship just by this webinar. And I always advise, do please consult with your own legal counsel or a billing and coding expert when we get into those type of concepts for specific advice and questions. We are here in an educational context today. But let's jump right in, and I won't spend a lot of time on it because I think some people spend too much time worrying about definitions and context here, but I do want to set the table for our discussion today by starting with a very short description of what we're talking about, at least when I use the terms telehealth or telemedicine. And in general, what I mean for purposes of our session today is what I'm generally talking about are the delivery of healthcare services through technology, where the provider is in one location and the patient at another remote location. I don't consider it, nor do I think it should be considered, a separate medical specialty in and of itself, but rather I focus it, really characterizing it as the technological conduit through which medical care is provided. So keep that framing in mind. And when you want to think of what does that mean from a real world application perspective, I kind of listed just some bullet point examples here on the slide, certainly not an exhaustive list. But these are the areas where I see, in the last 5, 6, 7 years have been gaining traction out in the marketplace, where I see these type of technologies really be leveraged. Direct to consumer, right? That's an arrangement where telehealth really started to, I think, really see an uptick about 10 years ago in a consumerism type of manner. So a lot of companies were cash pay only, started in a direct to consumer or DTC type of business model. Destination medicine also, I saw a lot of programs coming based on that, and that's an example of where a center of excellence at a hospital or an academic medical center can use technology to draw patients from around the world or around the country. And I'll talk a little bit about that a little bit later in this presentation as well. You have hospital at home programs. They existed for a while, but during COVID is when you really saw the hospital at home programs start to take off. RPM, remote patient monitoring, especially once Medicare started reimbursing for that back in 2018, seeing an uptick there. And health plans and government payers and employers, right? Those are the healthcare stakeholders where many of us receive our healthcare, right? The job we work at, they have healthcare. You're seeing more benefits provided that include telehealth technology. Health plans are starting to expand in reimbursement and be more innovative in how they can manage their members and provide benefits to them. And then government payers, right? Medicare, Medicaid, managed care. They've also had additional innovation and open-mindedness really to expand reimbursement. And that reimbursement is what can really drive a lot of the innovation in the industry. I think, and the one thing I'll say before moving on from this slide, I like to give the example of how we saw the banking industry develop, particularly because it was driven, I think, a lot by consumerism, right? It used to be that to do your banking, right, you used to actually have to walk into the bank. You'd walk in, you had checks, you had cash, right? And then there was some innovative banks that said, hey, we have this great online banking or mobile banking, and they use those terms for marketing purposes, right? Mobile banking, online banking. And now most people, I think, just call it like, it's just, that's what banking is, right? You have your app, you have maybe a website, and that's what you consider. Maybe you go inside because you need to get a loan or sign something, but you just consider it all together. So there's no like special terms, right? And I think that's where we're eventually going to get to for a lot of telehealth or digital health, is it's just another form of healthcare, and it's going to be natural and expected from the industry. And I think, again, driven by expectations from patients on the convenience of it and the ability for those to have access in places where they historically may not have existed. All right. So I want to start early on in the presentation by talking about overlapping layers of regulation, right? So part of why our healthcare system, I believe, is so complex, and it has to do with the maze of laws and regulations that exist and how they interact with each other. This slide just represents, I think, some of the 4 key layers that interact with each other, at least from a legal and regulatory perspective. So you have like the federal law, right? So the national federal law, that's typically the floor, right? You want to make sure you're complying with federal law when you're looking at an issue. That's one of the first considerations. Is there a federal law on point, and does it apply and what does it say about what I'm trying to do, right? And so keep that in mind whenever we're talking about healthcare, because that's often, it has a lot of federal components to it. Even if you're complying with federal law, the analysis or your inquiry won't stop there. You also want to make sure you're going to meet any state law requirements that you're in. And state laws at times can be more restrictive than the federal laws. So keep that in mind as well. Just from an operations perspective, you'll have to look at federal law, state law, finally, payer rules and industry standards. You want to know, can I do something? Am I going to get in trouble from the federal, law enforcement? Am I going to get in trouble from a state medical board or state attorney general? And then if I'm doing something, can I get paid for what I'm doing? And that's where the payer rules come in. So you not only have those legal requirements, but you have payment requirements. And those can be from your commercial payers. It can be from the relationship you have with the self-insured employer. It can be from Medicare and government payers, et cetera. So these are all things that have to pay attention to. It can be complex because they can differ in the different contexts. But it's the system we live in today. It's why I have a job, right? And why it can be some complexities in navigating these laws. There are solutions most of the time. There are models out there. So there's ways to do it. It's just something that you're operating in a highly regulated industry. You have to pay attention to that. I'll give you like a concrete example of how this all plays together. And I'll talk more about this example later. I know we're going to have probably some questions about it because it's a hot area, but I'll start for this particular slide example. I'll give you the Federal Ryan-Hyde Act. And the Federal Ryan-Hyde Act relates to controlled substance prescribing. And it's an old law. It's been on the books for a long time. It's a federal law. And what it says, and I'm going to be compacting this and simplifying it for this particular example, but it says with limited exceptions that a provider must first have a physical, in-person, face-to-face visit with a patient before that provider can prescribe a controlled substance with that patient via telehealth, right? So that's been on the books for a while and existed pre-COVID. So that would be a federal law, right? And so if you have a telehealth company or if you're a provider that wants to prescribe controlled substances to patients via telehealth, you have to comply with that law. You have to see the patient in person. So even if you lived in a state that says, hey, go ahead, we don't care, we think telehealth is great, we have no restrictions, we can bless, and we say as a state, we have no restrictions on prescribing via telehealth for controlled substances. That's great if for the state to do that, but you still have the federal law. And so the federal law is more restrictive. You have to comply with the more restrictive law. Another good example, same long lines of thinking, during the public health emergency during COVID, that federal law I just mentioned, the Federal Ryan-Hyde Act, there's been a waiver in place to say, look, even though before COVID we had this law in-person requirement, we're waiving that during COVID. And that actually has continued to be extended since the public health emergency has ended. So now you look and say, hey, no federal law restriction on that. That would be great. I'm in a state that says I can do this. Maybe then you have a pathway forward. But there could be another state that says, we don't care what the federal law says. We want to be more strict. In the state of X here, we are not as bullish on telehealth, and we think there's issues, and so you can't do it. Again, the more restrictive law applies, so the analysis is you still would have a regulatory issue in that particular state. So I just wanted to give an example of how all of these can work together. And so you all that have been paying attention still, if I haven't lost you, your honorary law JD degree for understanding that. Okay, so now I want to talk a little bit about time. I want to spend some time jumping into discussing some of the other legal and regulatory issues specifically that can arise when implementing and operating telemedicine arrangements. And so this pinwheel, I've used this slide for a long time. It addresses some of these more common regulatory issues affecting telemedicine. It's a little bit of like an old joke on play on the traditional hub and spoke model that some of the original or early telemedicine arrangements were modeled after, where you had like a specialist provider at a hub hospital connect virtually to patients that presented at a spoke, hospital site, like in a rural area. So that's kind of like the pinwheel thing, why I use that. But these are examples of laws and concepts in areas that are constantly changing. They're in flux. They can vary from state to state in these key areas. Again, this is not an exhaustive list, but enumerates what I think are the more common or important issues that you should be cognizant of in order to effectively deploy telemedicine services. And so I just wanted to kind of give an example of these. We're going to talk about a number of these again during this presentation. So let's see. And in this next couple slides, I'm going to show you not only the issues associated with some of these, but some trends that we've seen both pre and post COVID. All right. So it wouldn't be a telehealth presentation if we didn't spend at least a little bit of time on the issue of licensing. And the reason you hear about licensing ad nausea almost from lawyers like myself or the industry stakeholders on telemedicine is because one of the key advantages of telemedicine, right, is the ability to provide healthcare to a patient, no matter the patient or the provider's location, right? However, right, since providers are licensed to practice in a specific state, they're only legally allowed to offer telemedicine services to patients in that state. And so to put it very simply, the basic rule of thumb is that the physician has to be licensed in the state where the patient is located at the time of the telemedicine consultation takes place. So if the doctor is located, let's say in Texas, and the patient is located in Florida, then that doctor who's physically in Texas has to have a Florida medical license in order to diagnose and treat that patient via telemedicine. And so if you use that same example, if that doctor is physically located, or excuse me, if that doctor is licensed in Texas and the patient is located in Texas, then the doctor who has a Texas license for the patient that is physically in Texas, that doctor could be physically located basically anywhere from a telehealth practice standards perspective, right? They could be located in Maine, New Jersey, the surface of the moon, really. There could be other issues of offshoring and things like that, but from a licensing perspective, that's the well-established rule in basically every state. And if you are you're a practitioner and you're just focusing on patient populations in your own state, this licensure requirement may not be an issue. However, in my experience, the type of companies, clients, and practitioners I work with that want to leverage telehealth, they usually have like an app or website or some technology. They usually want to scale and see patients in multiple states, if not nationally. And so once you get into that multi-state practice posture, that means you're going to have to watch this licensing issue and make sure your providers are licensed in the state where the patients are. It means you're going to have to submit license applications. You're going to pay dues, get CMEs. So it's just a paperwork thing, but you want to be aware of it. It's an operational challenge. It's a staffing challenge. And there are solutions out there. There are consultants that can help with the licensing. There's the different licensing compacts that can help streamline the process. And there's technologies that exist out there that can help match up the geographic location of the patient with the provider. Again, adding to the complexity and rabbit hole is our healthcare system. The rule of thumb is the rule of thumb, and there are exceptions, and the exceptions can vary by state. And so that's on the right side of the slide here. And these exceptions are not, again, exhaustive. They're the ones that are commonly used that I see. And a lot of clients I work with leverage these in certain situations. So I'll start with the kind of from the bottom up on this slide, like the follow-up care exception. There's about 14 states. There used to be fewer. The trend has been to increase that. There's about 14 states that have a follow-up care medical licensure exception. And the example of this type of exception in sort of action is that you can have, let's say, like a hospital physician provide post-op follow-up consults without having a license to practice medicine in the state where the patient goes home to. So let's say patient is an Illinois resident. They fly to Massachusetts for a specialty surgical procedure. That patient could fly back home to Illinois and receive a follow-up consultation virtually, maybe, right, from that physician in Massachusetts who doesn't have an Illinois medical license. There's an exception for this. So you don't have to worry if you're that Mass licensed physician that, oh, am I conducting or operating an unlicensed practice of medicine in Illinois? The state of Illinois has an exception for this. That's the follow-up care exception. And like I said, about 14 states have that. Another exception is the special telemedicine license. More states have this. About 19 have some variation of a telemedicine special purpose license. The gist of these is they're often cheaper than a full-fledged medical license, more streamlined, and sometimes they have restrictions like you can only provide services via telehealth, or you can't have a brick and mortar location or presence. So I see those utilized. Bordering state exception is another one. The term kind of describes it. It allows contiguous states, an exception for contiguous states. Again, sometimes we'll have limitations about not having an office in the state where you're utilizing the exception. And about 10 states have a border state medical licensure exception. The last one, and I think probably the most powerful and one of the most common ones I see, is the peer-to-peer consultation exception. And it exists, or some form of it exists, in almost every state. And the exception allows an unlicensed physician to practice medicine in a peer-to-peer consult with a local licensed physician. There are a lot of limitations that can, and like caveats to that, depending on the states of what you can and cannot do utilizing that exception. But I see it used a lot. And this is an example. This chart has some states that you can see as examples of some of those nuances that exist within the exception itself. And so you can see they can differ by state, and we have all of those rules in every state. I'll give like a good concrete example of a peer-to-peer consultation exception, and that's in the context of second opinion offerings, online second opinion offerings. And in online second opinion models, the patient typically will, usually through some online funnel, will come across, let's say, like a nationally recognized hospital. Like you are a nationally recognized hospital's website, and that patient might be curious about consulting with a world-renowned specialist at this famous hospital, right? But maybe the patient's out of state, right? They're further away geographically, and they think they have maybe like a disease state, like a cancer or some specialty condition, but they're far away and they don't really want to commit by flying all the way out to your hospital just for an initial consult, because it's still, a little speculative. These second opinion models allow the patient to have that initial consult, such that that patient can get initial feedback and say, wow, these are the rock star clinicians. This is where I want my full-time care to be for whatever, the specialty condition I have, and then reach out to the hospital's intake and schedule my in-person, visits or sessions. And so that model kind of removes that entire need for that first speculative initial visit. And it's immediately reducing a significant cost barrier and geographic barrier at the same time. And if you just, right on your phone now, you could Google, if you Google like online second opinion offering, you'll see some of the big brands in healthcare already doing a lot of this. The Cedars-Sinai's, the Mayo Clinics, the Stanford Medicines, the UCSFs, the Cleveland Clinics, right? That's all publicly. If you Google them, you'll see they're advertising these online second opinion models. And they're using this destination medicine, one of the key applications I said earlier in the presentations, to attract more patients across the country and provide better access to their specialists. And these programs are heavily utilizing often the peer-to-peer license exceptions, so that their specialists don't necessarily have to be getting these licenses in all these other states. They're utilizing that exception to provide that initial consult. All right. Another one of the orange pinwheel considerations that was on there, and another hot area that I deal with, are modalities. And those also vary by state. And what that term means is like, it's a fancy term for talking about the type of technology or communication a provider must utilize to interact with the patient at different points during the patient journey, right? So a company like Spruce is a typical modality technology type of how you communicate with the patient if you're a practitioner. There are really four buckets that I put technology modality types into. The first is synchronous, right? That's like the video visit. That's like right now, if you and I were talking on Zoom, that's a real-time interactive audio-video communication. That is considered the gold standard from a regulatory perspective, and every single state will allow you to establish a doctor-patient relationship with real-time audio-video. The other bucket is asynchronous, sometimes also known as store and forward, and depending on the context, and also a very powerful tool. It allows providers to time shift their delivery care by allowing providers to tackle a large group of consults at a single time and on the provider's own schedule, so you don't have to tee up the exact real-time interaction. And it can involve e-consults, text or email inquiries that are a discrete medical event. And that's a growing modality. It continues to grow over the last few years in its popularity. Everyone likes the text-based interaction nowadays. Interactive audio. This one was sort of invented by lobbying efforts by Teladoc over a decade ago. It involves an audio phone interaction, but also extrinsic medical evidence along with that. So like maybe the doctor's reviewing the medical chart and then calls the patient. But another fairly prevalent modality under state laws. And then RPM, which is a little bit different as well, right? That's where the patient has data collected from from usually some sort of technology like a wireless scale or wireless blood pressure cuff. And then the provider care team can provide ongoing monitor and assessment of the patient's health status and symptoms, and then if necessary, intervene if there's like an acute episode or something like that. Okay. So here, so at Foley, we track all of these modalities, all of these practice standards, all the controlled and non-controlled prescribing rules across the country in all states. And so it allows us to see the trends, it allows our clients to see the trends and know the rules at any given time. And so I have for you all today some heat maps nationally that will show you the changes that states have had with respect to modalities, like the technologies that they allow to establish the doctor-patient relationships back in 2019, and let's compare it to 2024. So you can kind of see where things are headed or have been heading. So here we have 2019, right? You can see on this map, well, maybe you can't see it, but I'll tell you, looking at the coloring categories here, no state prohibits, in 2019, no state prohibited a physician-patient relationship from being established solely through telehealth. So you could have a virtual-only encounter, and that was fine in every single state. But in 2019, what you can see is that there's about maybe a little less than a third actually required some sort of synchronous or real-time component to initiate that physician-patient relationship, right? That's what the color coding is there. You can also see that some states even required a live video exam, that real-time video visit. So like Arizona, Maryland, Ohio, Idaho, Nevada, required that video visit, and then some states required at least the interactive audio as well. Back in 2019, about only a third of the states recognized asynchronous for establishing the relationship, and most states were actually silent on that, which means the rules didn't address it. And oftentimes back then, even still, was because the boards hadn't thought about it. They didn't do this on purpose. It's not like they said, oh, we're not going to say anything and be silent to add more flexibility. They just didn't have it on the radar as much back then. And so let's jump into the present day here. So this is 2024. So let's see if I can go back and forth. So 19, I'll just kind of go back and forth so you can see some of the color changes here, right? 2024, you can tell the map looks a whole lot less dark blue, right? And most strikingly, I think you'll see states like Idaho, Nevada, Ohio, they moved from requiring that video visit to expressly permitting asynchronous modalities, right? And then here as well, New Mexico and Mississippi now are the only states requiring a video visit interaction. You can have all other states require more flexible technology modalities. And so that's kind of like you can see the trend. And if you want to say like, well, why did that happen? I think the few reasons are one, the public health emergency and COVID prompted a reexamination of the regulations to be more flexible. It became a hot topic politically. It's on people's radar. People were more accepted into the concept and buy-in of telehealth. So there's more utilization, more experience with it, less like unknown or less fear. And then there was also a lot of advocacy led by agencies and organizations like the American Telemedicine Association, for example, and others. Okay, so this is just another way to visually depict the growing adoption of asynchronous telemedicine. So now there's only 9 states that basically do not allow it, right, to establish the doctor-patient relationship. 28 states now allow for it, right? So 9 say you can't do it async. 28 now say you absolutely can. And then there's the 17 states that I consider them modality neutral, which means they don't mandate or talk about a specific modality type. They usually like broad language that says like secure electronic communication and information technology, right? Like Florida's a state like that, which I think is super broad and usually will incorporate the asynchronous type of technologies. Okay. Okay, so I also want to talk about commercial insurance statute laws, because these also vary by state. This is also a trending, I think, in a positive way. We just actually released, and this is a free resource. We have the link below for anyone that wants to check it out. But it's an updated 50-state survey on the telehealth insurance laws, and it's a report on each state's law about commercial insurance coverage and payment and reimbursement laws. And we compare what the laws looked like before the public health emergency and then after. And so you'll see we also have heat maps here representing, all the states that have some sort of commercial insurance law on the books. So most states, right? 43 states plus DC have some sort of commercial insurance law. And what's important to know is that there's I think two main concepts when I talk about in commercial insurance laws. One is coverage. Is there a law that says, hey, health plan, you have to cover the telehealth, right? And then the second concept is, I call it payment parity, which is not only, hey, health plan, you have to cover this telehealth service, but you also have to pay for it in an equivalent manner that you would pay for it in an in-person setting, right? It's not like you can charge or pay the doctor $100 in person and only $50 in telehealth. So two concepts, right? Coverage, are we going to pay you at all? And then how much are we going to pay you? And are we going to make it equal to or similar to an in-person context? So again, I think you can check out the link. It's the website there in the report. You can download it. All right. Controlled substance. I think, and I'm trying to look at, I'm multitasking here, everyone. I know I'm getting questions in, and it seems like a lot of them, and I'll have time for Q&A at the end here, but I'm also trying to keep an eye on them as they go. Looks like most of them are related to controlled substances. So I anticipate we'll have more questions on this. And it's a hot area right now. And there's a lot of focus on controlled substance prescribing, particularly as, I would say the mental health is becoming more of a growing concern across the country, right? So talked a little bit about the Ryan-Haight Act already. It's the Ryan-Haight Act. Some people say Ryan-Haight Act. I think it's pronounced Ryan-Haight Act, but someone will tell me I'm wrong if that's wrong, but I think it's Ryan-Haight Act. And it was, I think it came out in like, I don't know, late 90s. And that's the federal statute that said, with limited exceptions, there are some exceptions that most of them don't apply to a telehealth setting, that there has to be a physical in-person visit before you can prescribe controlled substances, right? Then COVID happened and they waived that. And that's because it was a waiver, but it's in the statute. In the statute itself, the Ryan-Haight Act, one of those very limited exceptions, and hopefully it continues to be a limited exception, is the declaration of a public health emergency. And that's exactly what happened in the COVID context. So the declaration was made, the DEA announced that was the exception was met, there would be a waiver. And so all throughout COVID, which that exception lasted, multiple years, 3 years, 2 to 3 years, patients were able to get controlled substances without ever seeing their prescribing physician in person. And I helped build, and there was a cottage industry that sprouted out of that, right? There was actually virtual only mental health providers that came out of this. There were opioid use disorder clinics that were virtual only. There were psychiatric and other mental health providers that leveraged controlled substances. And there was a lot of that controlled substance, a lot of utilization of that exception. Then the public health emergency ended, and everyone was like, oh no, what's going to happen? Are patients going to be grandfathered in? Are patients going to be, cut off all of a sudden? Is this going to affect really good treatment that they've been receiving? And so there was a lot of unknowns. And essentially, there was some fumbling by the DEO on how to handle this. Ultimately, a whole lot of nothing happened, and they just punted it a little bit further down the road. And they said, look, we're going to come out with something. Stay tuned. And the anticipation is for them, the crystal ball, although there's no guarantee, is that sometime this year, the DEA is going to come out with a process. I think it's going to be under the special telemedicine registration that Congress and the statute has allowed them to promulgate it, 10 to 15 years ago, and they still haven't done it. I think they're finally going to do that. Fingers crossed. And that would allow for a process by which a practitioner could register, could be in the system, could get approval essentially to do prescribing of controlled substances using telehealth without ever having had that in-person physical examination of the patient. And I think that's super important, particularly given the psychiatric shortage that we have, particularly given a lot of these do have clinical efficacy behind these programs. They're virtual only. So I'm an advocate and a champion of that. We hope it happens. I think it's something I'll talk about in one of my last slides here to anticipate happening in 2024. So that's the federal law of the Ryan-Haight Act. But remember, there was like the second or third slide. I talked about the overlay of regulation. So let's say we get the we're optimistic we get the federal law flexibility to be permanent, or we get a process. That's great. But then we cannot forget that we have the state laws, and that's something that also has to be met. So not only do you have to comply with federal law, but the state law. And here is, you can see, we're going to do the same quick exercise. 2019, 2024, what's happened? And so you can see here the 2019 slide about controlled substance prescribing. We can see some states had a limitation, some expressly prohibited it without a prior in-person exam. And I think this is an interesting area. 2024, I'll go back and forth so you can see the color changes, and you all can get copies of the slide. But you can see there's a good amount of difference here, right? So in a 5-year period, you had a good chunk of transition to be, I think, more flexible. But there were some states that actually became more restrictive, like Alabama. So if I go back and forth here again, you can see the change in Alabama. Alabama actually was silent and then basically said no to controlled substance prescribing via telehealth without an in-person visit. I think that if we come out with a favorable DEA policy, I believe, this is my guess, that we're going to see more favorable state policy too on this issue. I think it'll allow for states to feel more comfortable if the DEA has a mechanism and is more expressly signing off on it from a federal policy perspective. All right. I want to talk about remote patient monitoring here for a moment here. Let me look and see if I have any questions that might be, we'll save them to the end so I can get through. RPM, remote patient monitoring, remote physiologic monitoring. This has existed for a long time, right? The actual ability to do it. The reason it's become a lot more popular is back in 2018, Medicare, the fee-for-service program, started to separately reimburse remote physiologic monitoring. And it was the first code was like CPT code 99091. Then the year afterwards, they expanded it into 3 additional codes because the first code was kind of clunky. And they've continued to provide additional guidance as the years have gone on, and sort of kind of like figuring out, building the plane as it flies, with the government figuring out what's and how to modify this coding guidance. And it's caused, I think, a big uptick. I do a lot of work in the RPM space because of, I think, the expansion of Medicare payment. That's not to say that at the moment, right now in 2024, there have been some pretty recent and significant speed bumps this year for RPM. I know my slide topic was RPM opportunities, but because of recent changes, it's more of RPM, I would say, hurdles the last couple of weeks or months. So the first one, which was going to be a big deal for this year, I think, involved the AMA and their CPT editorial panel. And for anyone that's familiar with RPM or works in the space or is an RPM vendor or company or provider, one of the requirements for reimbursement under Medicare is that you collect about, or at least 16 days of RPM, or remote therapeutic monitoring, also has this RTM or RTM data from a patient over a 30-day period, and that is one of the criteria for Medicare billing. And it's been a sticking point because that 16-day requirement is not grounded in any sort of like clinical requirements. It's sort of arbitrarily created by the AMA and and adopted by CMS. And there's a number of clinical use cases or disease states where you don't need 16 days of data, separate data in a 30-day period, or that could even be bad for the patient. So a lot of industry stakeholders have been pushing back on it for a while. It's hard because of patient adherence issues, and it directly affects the bottom line of some of these companies that are trying to offer this service. And so earlier this year, there was a proposal before the AMA they have a CPT editorial panel, which is responsible for creating medical billing codes. And then in the May meeting, the committee, talked about it, and the discussion of the code changes to potentially modify that 16-day requirement, or probably have a new code with a lower requirement. Those discussions sort of stalled out, and to my knowledge have been postponed indefinitely. The next meeting they have is in September of this year, so we'll see if they try to take it up again. But there was a little bit of fanfare before their May meeting because it was on the agenda. People thought they might actually have momentum and make some changes that then could be adopted by CMS, but that doesn't look like it's actually going to be the case. The other, I think, setback that is of note, because it got a lot of press, was it came in the form of a report or a study that was released by the Peterson Health Technology Institute, so the PHTI, and it was a fairly scathing report or study scrutinizing remote monitoring diabetes management solutions. And the report suggested that rather than reducing expenditures and costs, which is what they're generally like advertising them to be, the value add for, they said that these digital management solutions, the report said that they're generally adding cost to the healthcare system, or at best, not really improving it. So that was something that, if you are a remote monitoring company, and it listed in the report certain companies they were not happy with or fans of. There's a lot of back and forth and arguments on both sides about the validity of the clinical study and whatnot. But that was a recent item in the press. And so those, I think, have been some speed bumps in the RPM space, just to share that with you all. I think we'll also see this year some expansion in guidance related to software as a medical device and digital therapeutics. They are, I would say, more positively, we're going to see more experimentation and hopeful expansion of some of those technologies. And they're sort of incorporated into, or they're tangential to, like, a lot of remote monitoring, RPM delivery models, or RTM delivery models. So I think those areas are also going to affect the evolution of RPM. Okay. So 2024, how are we doing on time? Okay, we're good on time here. So I would have lots of time for questions here. This is one of my last slides. So we will address some of these bullet points here. And this slide, I want to talk about 2024 and maybe a little bit into 2025, like what's going on this year. What does the fortune teller say? And I think there's a lot going on this year. Some, like the ATA, the American Telemedicine Association, has coined the phrase. I think they're the ones that coined the phrase, but they use the term, this is the Super Bowl year of telehealth. And the reason is because there's some big policy issues that could be impacted here this year. The biggest one, or one of the biggest ones, I think, is we're going to see what Congress is going to do with respect to passing or not passing legislation to make the Medicare billing flexibilities for telehealth permanent. The big, namely to kind of like synthesize it, to allow patients to receive telehealth services while they're at home and to have doctors get paid by Medicare for it. I mean, that's to put it in its most simple terms. Like, are we going to allow that is CMS going to allow for that? And it has to be done through Congress, not CMS, because this is a statutory reimbursement issue. The latest is what I'm seeing is that we think Congress is going to punt on this again and maybe pass another 2-year patch kind of bill that will allow for further study and review on the impact of making such policies more permanent. So again, if it's a 2-year sort of interim piece of legislation, I don't think it's the big win the permanent legislation that the industry wants, but certainly better than actually resetting to what it was prior to COVID. Because prior to the PHE, Medicare did not pay very much for telehealth because there was a list of draconian requirements that had to be met. One of the biggest ones is the patient couldn't be at home. It had to be real-time audio video visit. It had to be in a rural area. It had to be in like a hospital. So not really how the industry has evolved. And that would be a major setback if it were to relapse. I don't know for sure, but I would be very surprised if that were to happen. I do think we're going to get this 2-year interim piece of legislation. Okay. Physician fee schedule. This is a big one every year. I don't sleep on it. It's a good one. We're probably going to get the proposed rule in about a month, and it's the Medicare Part B physician fee schedule proposed rule. And there's a lot of stuff in there that relates to telehealth. They can propose new billing codes. They can give guidance about like RPM and supervision and all kinds of things. And so that is where some of the blocking and tackling from a regulatory perspective of what you can and cannot do, and the guidance to give you confidence about what you can and cannot do with respect to payment comes into play. And so that will come out. It's also a super important part of the process because when the proposed rule comes out, you can comment on it. And so if you have any sort of passion or you're involved in telehealth in this industry, please do comment on it. Let your voice be heard, because they do read those comments. And so they can get the feedback from the industry of what's actually happening. DEA special registration, I talked about that already, that we're expecting that this year. I think that's another big one. This penultimate bullet point, right? Corporate practice and private equity is kind of new trend that we've seen this year. And there's been a series of state bills, and there's also been some talk at the federal level, but I'm more interested in seeing how these states play this out. But these bills are gaining traction, and these bills, the way they're being written, could significantly restrict how any non-physician owned healthcare companies operate. So, particularly the target has been on private equity backed or venture capital backed or privately held healthcare companies that operate in the healthcare industry. Oregon had a fairly robust bill on the corporate practice of medicine that earlier this year ended up not passing, but that had some, I think, very restrictive language. California right now has some pending legislation. These would be very they would make a big ripple in the industry, especially in a state like California, as big as it is, if any of these laws were to pass. And it could be, whether you're for it or against it, it would likely bring in a lot of change in how companies and healthcare is looked at from a structural perspective and from an investment perspective in those states. So keep an eye on those. We are as well, and try to write about them as new developments occur. The last one is another big one is, I think we're going to see some more orange jumpsuits coming out from fraud and abuse. I think there were, in particular last year, the OIG, Department of Justice, and the Office of Inspector General released a special fraud alert. Which basically means they're seeing a lot of fraud in the RPM space. And they said, hey, everyone, just want to let you know, we're putting this on notice. There's a lot of fraud here. Don't do that. We are keeping an eye on it. And there's been other, I call it telefraud arrangements that they've been cracking down on. So the government, and as the industry continues to expand, and there's more government dollars being paid for, and more patients receiving it, and vulnerable patients at risk for fraud, the government's going to get more involved, and you're going to see more crackdown. And that is going to be certainly for the egregious cases that are like the real criminals that are doing really terrible stuff. But even when that type of fraud and abuse enforcement increases, then it starts to get onto the fringes too, where you get now more technical payment audits, where you thought you were doing the right thing, but your interpretation was different from the government's, and they said we shouldn't have paid you that, and they want all their money back, right? That has existed in hospital Medicare system for years. It will eventually, and already has started to creep into the virtual care world as well in telehealth. So if you're in that space, that's there for you too. All right, so we have about like 10 minutes or so, and I want to be able to take questions from everyone here. So before I will also, while I take questions, I have my contact info here. If I don't get to your question, or if there was a topic here that I didn't discuss that you want to ask me, or if you wake up in the middle of the night with night terrors of some telehealth issue and you just want to talk shop, I'm happy to talk with you. I have my contact info here. Another thing to just plug, because I think it's valuable, it's free, right? And free is always great. We have a blog, healthcaretoday.com. We write a lot about a lot of these telehealth issues. It's again a great free resource. For example, there's like probably 5 or 6 blog posts on controlled substance prescribing via telemedicine, both federal and state law stuff. There's a lot about the Medicare flexibilities, et cetera. And we try to keep that fairly up to date, so there's a lot of good stuff there. So feel free to be aware of that and use that and get those updates. Okay, so Carrie, how do we want to do this? I can kind of go through and I'll just kind of scroll through. I have, I think, some of the Q&A here, but I'll try to address some of these, but feel free, Carrie, to like play the Oscar music and drag me off the stage.
Absolutely. Yeah, there are quite a few, some overlap across questions, but I would say just kind of start at the top and like work your way down, and you'll see some duplication in there.
All right, so one of them I will, and I'll try to read them out loud here first. So one attendee provided the question regarding the controlled substance prescriptions for patients who live in different states from the providers. Do physicians need to obtain medical licenses for those states in order to send out prescriptions? It's a good question, and I'm going to give you a 2-part answer. The first consideration is the physician has to be licensed in the state where the patient is when they are treating the patient to write the prescription. So if I'm a patient and I'm here in, let's say, like Florida, and you're a doctor and you're located in Texas, I'm just picking on Texas today, then you have to have that Florida medical license to write me the prescription. And the federal law is waived, so you may not have had to see me in person. There's a second part, and that would be compliant with federal and should be with Florida law too. Then there's a second, more practical part of this that I've been seeing, and that is, okay, I am a patient. Now I have this prescription in my hand. It's a valid prescription. I am in Florida, you're in Texas. I'm going to take this prescription and I'm going to walk to my CVS or my Walgreens or my local mom and pop pharmacy drugstore, right? And I'm going to give them my prescription. Well, what we've seen is that mom and pop drugstore, the big retail pharmacies will say, hey, this is from a practitioner, a prescriber that is out of state. We see that they're out of state, even though they have a Florida license, and they're concerned about drug diversion or improper prescriptions. There are some bad actors. And so some of these big retail pharmacies have said, as a matter of policy, we know the law says this is totally fine to do, but we're going to say we're not going to fulfill that prescription. Thank you very much. Good luck trying to find it somewhere else. And that's what we're happening. So legal issues aside, you can do everything compliant, but because of the risk that they've seen with the opioid crisis that was going on, a lot of these pharmacies are just a little bit gun shy about the prescribing activities. And so they have created these corporate policies. And so I've seen that loosen up a little bit more recently, the last couple of weeks and months, but particularly last year, I saw a lot of that as an issue. So I hope that answers your question. I think legally, in the model you gave, yes, you can do it. Practically, could there be hiccups? Yes, and that would be based on the particular pharmacy's policies and how conservative or how aware they are about the controlled substance prescription itself. All right. The Ryan and Hayes Act, does it apply to Suboxone? Buprenorphine, yes, is a controlled substance. Can you talk about prescribing across states? If there is there anything coming down the pipe for loosening of these rules? I'm in Illinois, but have a license. I will say, look at our heat map. So you can see, I do think that there will be more of a loosening of controlled substance prescribing rules on the state level as the DEA and the federal policy loosens up. So I think that's where the trend is. But not always. Alabama was the example that could added some restrictions there. Any idea on how much longer there will be a waiver in place for the Ryan-Hyde Act? Right now, I believe the waiver is in place until the end of this year. That's what they passed, I believe it was last year, and the end of 2023 is when they passed the extension. So formally and technically through 2024. We are all hopeful and optimistic that there will be either an additional extension and guidance that comes out before then. If I had to bet on the horses, and don't hold me to this, but this is my best guess, and I've been wrong every single time before this when I thought they were coming out, so take it with a grain of salt. I think they are going to come out with some sort of proposed rule and then also do an extension to allow for stakeholder feedback before they finalize that special telemedicine registration. That's my guess. So that's something to keep an eye on this year. Let's see. What if a student is studying in another state temporarily or a person's on vacation? So I'm assuming this is like a licensure question. So let's say I usually live in Florida, or let's say I go to school in Florida and I go home to Massachusetts on summer break. And let's say I have a mental health provider that, they're with me year round and I talk to them virtually. How does that affect the licensing rules? Technically speaking, the rules stay the same. There is no exception for like a traveling student in that context, like a summer break context, not that I'm aware of. So technically that mental health practitioner, that psychiatrist would need to be licensed in the state where the patient is. And that would be Massachusetts when they're at home in Massachusetts, or in Florida when they're at school. The reality, I see some people take on that risk, that licensing risk. There are arguments of continuity of care. Could a medical board take issue with this? They could, right? Legally speaking, technically speaking. So that would be, I think, something just to talk about with your legal counsel, your compliance officers on what the business model is and how you feel. But I would say in the example that you gave, that could be it'd be a legal issue potentially. Okay, I'm just trying to see. What's the bordering state rules? Can a Virginia licensed provider treat patients in a bordering state? What does it say? Like DC and Maryland. The border state rules usually not every state has one, right? So let me just start there. But the ones that do, it usually involves contiguous states. There's about 10. I think the question here was, can a Virginia licensed provider treat patients bordering in DC? But I think so. DC, I'm pretty sure has one. There's 10 states that have it. DC, I'm pretty sure has one. I'm pretty sure Virginia can have one, but the board never promulgated that exception. I think it's like one of those like in purgatory type of influx rules. But you'd have to just look at those rules, or if you want to message me or remind me offline, I can double check for you. But assuming that they both did DC and oh, you didn't say Virginia, you said Maryland here. Maryland does have one. So let's say DC and Maryland, without looking at the rule, I'm going off of my memory. If they're contiguous states, usually then that will mean if I live in DC and in my practice is in DC and we're right next to Maryland and the patient comes in to see me in DC maybe, right? And then they go back home to Maryland and they want to do a telehealth visit, that would be fine, even though I'm a doctor that doesn't have a license in Maryland. And I don't know the rules off the top of my head on the caveats, but some states will say you can do that, but you can't also have a physical brick and mortar practice in Maryland either. You have to just stay over in DC and have this exception only used for like the patients that travel back and forth, as an example. Let's see. We're doing good on time. Do you expect telemedicine across state lines to become more or less common going forward? In other words, do you expect telemedicine regulation to become more or less restrictive? I think it's going to be way less restrictive. It continues to trend that way. That's my hope, and I think that's going to continue to be. As far as like, is there going to be any sort of like federal medical license or uniform license for physicians? I don't think anytime soon. I wouldn't hold my breath on that. I think the states, it's a constitutional states' rights issue, and I think a lot of the states are going to say they want that control as well, at least in the near future. Are we using the term physician universally? Will this apply for NPs too? Most of this applies to physicians on my heat maps. Those are medical practice rules. Then the rules for nurse practitioners or advanced practitioner types are similar, but there could be some differences among the different practitioner types and among the states. We do keep an eye on both in all 50 states for NPs and PAs, and so if you have a specific question, I can address that too. Let's see. How do these peer-to-peer second opinion options apply to NPs? Same answer. Like we'd have to look and see what those rules are. I don't think we actually have done like a comprehensive multi-state analysis for NPs on the peer-to-peer consultation exception. I'd have to double check that. So I'm not sure I know the answer to that one, at least off the top of my head. See, I'm even picking out questions and telling everyone I don't know the answer to them. So you're getting the real deal here. Okay, I think let me do a couple more. Let's see, I don't want to do the administrative stuff. Okay, for states that are silent on the doctor-patient relationship, are we supposed to practice synchronously only? That's a really good question. This is where like your lawyers can help you on this. The way I approach this particular type of question is, and to clarify the question for the attendees here, let's say you're in a state and some states will say asynchronous, store and forward, you can certainly establish the physician-patient relationship, go for it. And some states just don't say anything about it, it's silent. Now, when I see something like that's silent in that state, and the context matters, so you want to see if there's anything else that's informative. But generally speaking, we live in a law where we say what you can't do. It's the type of laws where like we say you cannot speed, you cannot jaywalk, right? We don't have a society or legal framework, generally speaking, where we have to write down everything that you're allowed to do, right? I don't have to pass a law that says, Taco Tuesday in the Ferrante household is allowed. There would be a law, it would be a weird law, right? So you can't do that. But that's how we deal with the legal framework in our society generally here. And so just because the law, there isn't something that says affirmatively that you are expressly allowed to do it, doesn't mean I think it's illegal. Instead, if there's no express prohibition, I would say your default would be to the standard of care. You also want to look and see if there's any other like board guidance on this, but generally I think the standard of care. So if you're a clinician, you say, look, I have what I need to care for this patient, establish a relationship, and it's an asynchronous modality type, I think you have a very good argument. And I think indeed some boards in their deliberations of whether pass laws do elect to be silent to allow for that flexibility. So that's the general interpretation I and many others in legal minds in the industry have taken. So I think the short answer to your question is probably not. I think you probably could do it, depending, again, a little bit more on if there's a different context. But Just not having expressive authorization under a state law does not mean like it's a dead end for you if that doesn't exist. Okay, let's see what else we got.
I'm coming back on because we are at the,
Oh man, I was having too much fun. We went over time.
yeah, there were so many good questions because you covered so much great content. And thank you for trying to get through them. For the folks still on the call, absolutely feel free to reach out to TJ. He's been kind enough to give his information here. And if you feel like your question wasn't answered or you have an additional question, he is there as a resource. Sadly, we're going to have to wrap up for the day, but that was incredible, TJ. Thank you for covering so much territory. And do you have any final words for the people that joined today?
No, like I said, because I feel bad I didn't get all the questions, you can, again, feel free to email me, check out the blog. Another good free resource for people that I always plug is it's called the Center for Connected Health Policy, CCHP. It's a not-for-profit. They also have a lot of multi-state resources on modalities and payment, and the American Telemedicine Association also is another good one. So again, I'm trying to give you all places for your questions to get answered. I saw a lot of good ones on the slide. Sorry we didn't get to all of them. Reach out to me, or you can do your homework on some of those other sites and to get your questions answered. Or you can spam Carrie and ask her all the questions too.
That's right. I'll forward them on. This was terrific. Thank you again for joining today. A wealth of information. Hope to have you back. This was terrific.
All right, thanks everybody.
All right. Bye, guys.